I mean, you might have confused him with like a small dog.
Ignoring the doctor's orders.
Because that's about the size they are.
Oh my gosh, no.
Especially up around the river.
Yeah, down, yeah. But it was, I always have a good time there. I haven't been too bad. Parts of GCACH I see them in, not everywhere.
I see them everywhere.
I'm trying to stay away from Castle Hill.
Kenny, make sure we had a
follow around.
No, no, I was, first time I saw, and that's the first time I'd ever seen a live rat ever in my life. And we were walking. Hey Sam, how are you? The congressional building. Good to see you, safe girl. You know, these are very internal. I missed you. This thing scurries across the sidewalk. And I'm like, oh my God, what was that?
Yeah, I took my mom to New York. She was very excited. You know, I've seen New York. She hadn't ever been. So we get there. We're there 20 minutes, not maybe if that. And she has her first. She's like, "Oh my God!" And I was like, "Yeah, by the way, this hasn't been on the big screen." She's like, "This is not how I thought New York would be." Right. And it was like we were there. We got there like midweek, so it was like the trash was out.
Oh.
So and it was just like, she was like, "This is not what I thought it was." I was like, "It gets better, Mom. Give it a give It'll be fine."
That was the thing in Florida too, man. You live in Florida. You're gonna have rats on the roof.
Oh, there's just rats.
There's so much water. There's so many things. It's so warm.
You know why you're hungry?
Anyway, you guys want to start?
I was so embarrassed. Well, are you ready? I think a couple of those parasites.
Yeah, I think so.
Yeah. Not as bad. They're smaller. Okay, but.
Okay, so where's Rhonda? I do not know.
Bless her heart.
I don't know where she's at.
She is MIA.
Yep. So I'm going to go ahead and pretend I'm Rhonda today, and hopefully I can do this as well as she does. So I guess we start out by opening the meeting, calling it to order. So thank you all for being here. We'll do a quick introduction. I am Brian Gibbons. I'm the representing providers, treasurer of the board, right? So, and I'm from Estrella Sunnyside Hospital.
Courtney Ward with the Mayor Group.
Hi, Courtney.
Jenna Shelton, Greater Columbia ACH.
Martin Sanchez, Greater Columbia ACH.
Atlas Hay, Community Plan of Washington.
Ruben Alvarado with the City of Pasco.
Martha Landman, Columbia County Public Health, Garfield County Health District.
Lauren Johnson, Greater Columbia ACH.
Sophie Gottman, Greater Columbia ACH.
Carol Moser, Greater Columbia ACH.
That's Stalnaker, Education, ESD 123.
Madeline Carlson with People for People, representing transportation and secretary of the board.
Becky Holm, I'm with Greater Columbia ACH.
Rachel Guest with Greater Columbia ACH. Diane Halo, Greater Columbia ACH.
Ruben Peralta, Greater Columbia ACH.
Wes Fletcher, Greater Columbia.
Sam Waddell, Greater Columbia.
Eric Nelson, Kennewick Fire.
Dana Otis with Lord's Health, representing behavioral health. Ronnie Batchelor with Lord's Health Network, and I am consumer representative.
Sandra Suarez with Yakima Valley Farm Workers Clinic, representing FQHC.
Very good, thanks. Would you guys like to let us know?
I'm Leslie Barron, and I'm with Myers and Falcon.
Roel Chavez, PHPW.
Randy Bell with Ideal Balance.
Sarah Clark.
Excellent, very nice to have you. Thank you all. So we have someone on the phone too, right?
You have Susan Grindle, Kittitas County Health Network, Social Determinant Sector.
Julie Peterson, representing hospitals.
Hey, Julie.
Jorge Rivera, Catholic Charities. Sorry.
Or Darlene.
Oh, so, okay, so you got Jorge. I heard Jorge. And Darlene, right?
Yes.
Okay, good. Anybody else on the call?
Carrie Green, Senior Life Resources, representing philanthropy.
Very good. Okay, thank you all for joining us this afternoon. So we can kind of jump in. First thing that we like to do, talk about the self-dealing and transactions prohibition. Make sure that we're cognizant of those things and that we don't have any conflicts of interest. Please, if you do, let us know. And we'll kind of move on from there, right? Anybody had an opportunity to review the board meeting, the minutes from the last board meeting? If you have, I would entertain a motion to approve them.
I move to approve the,
8:14.
from 8:14.
Thank you.
Second.
Excellent. Thank you. Any comments? Thank you very much. All in favor?
Aye.
Any opposed? Thank you. Okay. Next up are the ACH reports and updates. Carol.
Actually, we do have the updated sponsorship policy that was in the board packet.
Okay.
So the reason we put this in the consent calendar is because we've reviewed it a couple times now. So the communications committee has made a couple more revisions based off of some feedback from Q3 applications. So within the sponsorship request policy, we removed the application window. We found that with Q3 applications that several applicants submitted sponsorships a little late, the request a little late, and so they needed the funds sooner. So we decided to completely take out the application window and the funds distribution window. That allows GCACH up to 30 to 60 days to release funds for sponsorships that are approved. It also allows applicants to submit throughout the year. For the most part, we were receiving applications throughout the year anyways. So we decided to remove that. I think the intent of that at the beginning was we thought we were going to be flooded with applications, which wasn't necessarily the case. So we were allowing applicants to submit throughout the year anyways. We also added a section under the evaluation criteria, and that's number 2.
Okay.
So that originally said regional scope, and instead of regional scope, we included verbiage that says organizations located in the Greater Columbia region will receive precedence for sponsorships over those located outside the region. So that's saying if, for instance, if your organization was based in Seattle, but your event is located in Greater Columbia, we may give precedence to organizations that are located within our region over that application located in Seattle.
Seems reasonable.
The last update was actually within the application acceptance letter. One of the committee members had mentioned that they wanted to include verbiage stating that the funds were used for the intended purpose as stated in the application. So we just added that verbiage.
Okay. Very good. So it sounds like you need, this is in consent, correct? You don't need a...
My motion was to approve the minutes, and
Yeah,
we didn't really do it because consent was in the motion.
Gotcha. Well,
So we can approve them separately.
all right.
I'm
Well,
sorry.
we stumble over those
No
occasions.
problem.
So, you're right.
So can I move that we approve the
Updated sponsorship.
updated sponsorship request policy?
Perfect. Thank you, Les. Any second?
Sorry, who had the second? Okay, thanks.
Any comments associated with the updated sponsorship policy? No? So all in favor?
Aye.
Any opposed? Thank you. Okay, you're right. I skipped right over that. Carol,
No problem.
thank you.
So as is the custom, we have our GCACH report that we provide every month to the board of directors. That varies a little bit from the community newsletter. We try to have more data and more analytics associated with the report, and as such, we have the trackers for cohort 1, cohort 2, and the dashboard and payment. So why don't we go to the trackers for cohort 1 and cohort 2, and then we can circle back and highlight any of the articles that are of interest in the report.
So this first tracker is from cohort 1. These are the organizations that were further along working with on practice transformation. On here, you guys will see a bunch of dates, and those are the dates. And either their workbooks on the line items that have due dates on them are the dates where they turn in their reporting workbook, which is every quarter. So you guys will see a lot of, 7/15 and then 4/15, because those were the deadlines for the workbook. But this by no means doesn't show how often with each organization. These are just dates where they're turning in documents that are required for them to be turned in. Jenna and myself are there at least once a month in their offices, having conversations with them, what's going good, what's going bad. We've had the opportunity to go over their quarter two notes that Sam gave us, based on their responses to the reporting workbook and the work that went into it. So we're focusing on the areas where, hey, we might need a little bit of improvement in shared decision making. Are we tracking that? Or, hey, we're lacking some risk stratification statistics. How can we improve on that? So, we really meet with them to see how we can better improve the things that they're already doing. And moving forward, there'll be there's 2 more quarters. One, the deadline's coming up October 15th for quarter 3. So there'll be more dates added on there. But this is cohort 1 of the practice transformation organization.
And then the next page is our cohort 2 status tracker. So like Martine said,
On the cohort 1, why are some in red and some are black?
The names that you see in red, those are the exemplar clinics that are contacted. So that's why we have them highlighted in red to show that they are exemplar clinics, that they're doing a lot of the work that we're requiring for practice transformation. They're already doing that work. And if some of the organizations need some help on, shared decision making or risk stratification, we can, hey, farm workers is doing a really good job with risk stratification. Maybe go and visit or, connect them with that organization so they can learn from each other. So but that's why they're highlighted.
Okay, thank you.
Did you say why some of them were blue?
I think that was, I'm not sure why it's in blue.
Okay, I couldn't see any reason, so I just figured it happened.
Yeah.
If it looks pretty, I don't know.
I'm not sure why it's in blue. Yeah.
Looking for significance.
Right. But so these are all the organizations, given that each organization is going to have 1 or 2 sites.
Mm-hmm.
So there's more, than the 23.
Okay.
so cohort 2, these are our former VHO organizations that transitioned with IMC earlier this year. And so they've started practice transformation. So yes.
Integrated managed care.
Oh, I'm sorry.
Thank you.
Sorry. Integrated managed care behavioral health organizations, VHO, that did integrated managed care earlier this year. So like Martine said, our cohort 1 folks, they are in quarter 3, but our cohort 2 people, they're just coming up on their first quarter. So we've kind of learned a lot as practice transformation navigators. So now we know how to kind of better go in up front and let people know what the data requirements will be for practice transformation. And so a lot of our cohort 2 organizations, they've just got a lot of our lessons learned, and we go in knowing more just what you need to do up front with data. And I would say a good amount of them are prepared to report that data next year. So they won't have to report data until January 15th, but we're already prepping them up front. So you'll see the dates where we've had the kickoff meetings with these organizations, where they registered in the CSI portal, where their contracts have been signed, and where they submitted their budget. And that's really all that they've been required to do as of now. Their due date is also October 15th, so we anticipate a lot of 10-15 on here next time, which is great. But a lot of them have already started filling in their workbooks. We're already having talks of going above and beyond the requirements of practice transformation and really scaling and spreading, which is the whole idea. Any questions?
I do want to add something else. On this tracker, you guys see 2 red cells on there. One of them is no longer red, so there's only 1 on there. So
So which one? My Pepsi.
Okay.
Why don't we go to the ORN tracker? opioid resource network tracker.
Yeah, so the opioid resource tracker is, we are contracted with Benton Franklin Walla Walla. They're the one that we have contracted with. We just received our scores and actual OHSU on the other 3 that we have now. And so for in Kittitas, it'll be Kittitas Valley Healthcare. Oh, let me go back. So Benton Franklin is Consistent Care and Blue Mountain Heart to Heart. Kittitas is Kittitas Valley Healthcare. In Whitman, we have Police River Counseling. And for Asotin, Columbia, and Garfield, we have Blue Mountain Heart to Heart and Tri-State. So Kittitas, Whitman, and Asotin County, and Columbia County, and Garfield County, that we are not contracted with yet. We're in the process of getting those contracts ready. We've received data for the first one. They have had actually a lot more inductions since this started. I just attended their meeting this week, and they had 43 inductions, which is pretty amazing considering that they have 100 to go. That's 100 that they're required to meet the contract, whereas the smaller organizations have 30 for the small areas. So that just so you kind of have an idea. And I have them all on the same cadence of reporting. So the next ones will report their data on 11/10 as well. Hopefully we'll get a contract out to them by the end of this month, and that we can get them started and going.
Okay.
So those 43 guys, where did they come from?
Oh, and all of them came from the syringe exchange as referral. And so the ORNs, Consistent Care and Blue Mountain Heart to Heart, want to go out with our navigators to kind of get in the door to the providers to say, hey, look, this is a resource that we want you guys to use, and be able to refer their patients to them, so that Consistent Care and Blue Mountain Heart to Heart can do all the care coordination for them. And so that's one of the goals that we're working on, is getting those in the doors with the providers.
Diane, could you kind of highlight what the purpose of the opioid resource network is?
So the purpose of the opioid resource network is to be a hub. They're going to be the hub, and then they're creating contractual MOUs with different organizations to be bespoke within their organization. And so that way, like Blue Mountain Heart to Heart can refer out to Somerset, because Somerset's one of them that they have a collaboration with. And so we're hoping to build these up in each area, in each location, so that there's one central location, and that they can refer out for housing, for food security, insecurity, and for other things, not just treatment. They're focused on that most like. We're trying to get them into and medicated assisted treatment is the #1 thing that they're working on for the patients with opioid use disorder, but they're also identifying more wraparound service that's going to be provided.
One cool thing that they've done is we went to their meeting a couple days ago, Diane and I, and they've come up with a 1-800 number on business cards that they're handing out to individuals, so there's an easy access through that. They also have flyers with care offs. They're thinking about, how do we add additional organizations like Union Gospel Mission, and where are these individuals going to be located? So they're taking a very comprehensive approach to this.
Yeah, they've really been boots on the ground, actually going to where homeless people would be to see if maybe any of those had any. But they have really set the stage. Our first ORN has really set the stage in one, and it's really great because then I'm going to conduct a work group with all 4 of these organizations so that they can share lessons learned, or this is how we're doing it. This is how, so that soon will be coming as well.
Yeah, there's some interest. I would imagine there's some interesting statistical stuff. I don't know that any of it's collected yet, or so early on, but you mentioned that all of everybody's coming from the needle exchange, right?
Yeah.
Exchange program.
So
Blue Mountain Heart to Heart runs the Walla Walla and the Tri-Cities syringe exchange program, and so.
Is it a single site or multi-site?
Multi-site. One in Walla Walla and one here in Kennewick. they also found that because the one that got closed in Pasco, they're finding that
Right, they're
a lot
busy.
of patients have not returned to the Kennewick site.
Right. It'll be interesting to see if they have, and they may have, just an extraordinary person at both of those sites.
Yeah.
Who's able to move.
They
and,
do, and that's,
right?
yeah.
If you don't have that influencer, it doesn't work as well, huh?
Right. They have 2 care navigators that stay at the site itself, and they're also started a rapid induction, which means that if they have a patient there, right there at the syringe exchange, that says, I'm done with this, I need help.
Yep.
They have a rapid induction so that they have a provider that's available right then, and then that nurse practitioner can get them on the medicated assisted treatment, which is it's awesome. They're also going to start doing one in Clarkston. They're going to do a van in Clarkston. So this rapid induction has really made a difference, and they're hiring. They actually have a nurse practitioner that is dedicated to the ORN, and so that's kind of made a big difference.
One nice thing about Everett is that he's really close to what the very latest research is. He's not just a care provider, but he's a researcher. And so, I mean, this
There's a lot of
idea,
data.
a lot of data, but this rapid induction thing, I mean, this is a game changer. If they can make that happen.
Yeah, those are your best practices. You got all kinds of best practices to harvest out of there. That's good. It's really good. It's fascinating. I wouldn't have guessed that.
Well, there'll be more information to come as this progresses.
Yeah, that's good. Thank you. Really good.
So I have a relationship with the mission, and I know what their pushback is. It's because belief versus actual numbers. Are you trying to talk with Andrew over there, or are you talking?
I'm not talking to them directly.
We're not.
It's their care navigators are. They actually have 2 dedicated care navigators that are dedicated to the ORN. They use the funding that they received up front to hire these care navigators to be part of the hub. So I can give you their information and everything.
Yeah, if you can, because I know that there's a lot of pushback.
Okay.
They were some of the game players in keeping it out of Pasco.
Yeah, I'm sure.
And so in talking with them and understanding where they're coming from, I'm kind of like a neutral party there. They don't know what my true belief is behind it, but thank goodness, because then they wouldn't talk to me at all. But it's kind of like just that on the bottom layers, taking information, and I'm able to express that information. So the pushback is religious versus reality. And I know that Cheris was running for a seat at the at one of the school districts, I believe it was. City Council for Kennewick, yeah, that's right, City Council. And that was one of her stand-on things, was no needle exchange. I know that she's pretty stringent about that, but as far as Andrew is concerned, Andrew's more flexible in understanding what those processes are. They have to work under their guidelines. And so it's understanding that, but still having to work within that framework of their mission statement. And so those are going to be hard needles to move. And I think that, so to speak, yeah.
Well, there's still
no pun intended, promise.
There's still a lot of stigma with the medicated assisted treatment, and that's kind of one of the reasons that we want to have the navigators take the care navigators from the Opioid Resource Network with them to the providers to kind of let them understand that what it is.
Well, once you get the data and something you can work with, sometimes you can use the data to link the mission.
Yeah.
And,
We use the data.
People can help you get there.
In the work group, so a lot of the providers that were in the original work group kind of see like the numbers that need to treat, and then see how many people have prescriptions. So we use the data a lot.
Yeah, no, that's really good. We're
We
good.
have that information on Ronnie to them the next time we meet.
Absolutely.
Thank you. It's really good. That's again, it's fascinating stuff.
My turn.
Your turn?
Yes, please.
Tracker.
So it's Desmond right here, everyone. The local health Improvement Network Tracker. So just a quick reminder on how this is organized. It's not organized in the typical quarterly, 12-month quarters. We kind of spill into January 2020, so we can step back and analyze 2019. So it's the first block that you see there is the quarter ending April 30th. The next one is the one that just ended August 31st. So that on that one, every local health improvement network completed their deliverables. We've paid already 4 of them, except for 2, Southeast Washington and Whitman, still 3% of the $5,000 check. And as you can see at the bottom of each block, you can see there's a running total of what they're getting. So you can see there where everyone's at. If you skip past the quarter ending January 20th, you see at the very bottom, the last 2, you see the Lynn Training Fund. We have set aside some money to provide for members of the local health improvement network for them to either bring trainers or for them to go to trainings or conferences. We haven't used any of that money yet, but just about every Lynn, there are plans in their meetings. They are talking about bringing trainers or sending people to conferences. The last block there is the sponsorship fund. That's where we're at. So far, only within the Benton, Franklin, and the Walla Walla region is where most of the sponsorship applications have come from. And if you flip the page, you will see a cumulative total mixed in with the Lynn contract, the $30,000, what they've received so far out of the $30,000 from the Lynn contract and the sponsorship money. You will see a cumulative running total there. The last 2 blocks is the Community Health Fund deliverables. All the Lynn areas and all the Lynn third-party administrators have received the money. Right now, the only Lynn and the other region that has been selected, the organizations that will address the social determinants of health is the Benton Franklin and Three Rivers Community Foundation. They're in the process of interviewing the applicants early October 4th, around there. They will be reviewing applicants and they will be making the selection soon after. So that's the Lynn tracker.
Okay.
Any questions?
Very good. Thank you. All right. Yeah, next, Ms. Carroll.
Well, we'll go to the GCACH report.
Mm-hmm.
I think I'll highlight just a few articles in here. One is about the permanent supportive housing project that Ruben Alvarado has been assisting with. So you might recall that Greater Columbia ACH was approached by Lourdes Health Network, I think, in February, expressing some concern about their loss of the mobile homes to support one of their PAC programs. So Greater Columbia ACH kind of stepped into this full housing environment and pulled together some really great partners that have been meeting since February, really to look at supportive housing needs, knowing that if you don't address the social determinants of a person's health, it's hard for them to, get excited about addressing their diabetes. So we held a summit in March, and we invited Rhonda Huff, our board president, to make the presentation, and then Rob McCann came down from Catholic Charities Diocese of Eastern Washington, which is housed in Spokane. We had a great turnout for that event. There was about 91 people there. We went back with a survey to say which model of supportive housing do you want community, and they liked the Catholic Charities model that has supportive services on the first floor that would include mental health, substance use treatment, medical, primary care, legal assistance, perhaps transportation, and then with the housing units above that. So since we identified that model, we've been working with Catholic Charities to put a permanent supportive housing complex in the city of Pasco. And the reason Pasco was chosen is because the Catholic Diocese of Eastern Washington, their borders are the Columbia River. Mm-hmm. So Yakima Diocese is in Kennewick, right, and Spokane Diocese is actually in Franklin County. So we've been working with the city to try to put a project together, and we'll be meeting in early October to talk about the financing, because for the package, they're going to need some backstop financing, about $350,000. So we put together some partners to take a look at what can we do collectively. We're working with the housing authorities, community action connections, our hospitals, LORDS, trios, CADLAC, to see what we can't do collectively to come together and help backfill the shortage. And then they're applying for a housing trust fund that is due, I think it was due the 15th of September, and then putting their financing package together for capital financing that will go out in January. So we've been having conversations with Senator Murray's office and our state legislators to say this is a project that's really needed in the Tri-City area. We don't have true permanent supportive housing in our region that's low barrier, so we felt that this would be really important. Oh, and the other important partner is Benton Franklin Human Services. So they are also a part of the mix because they really run the Continuum of Care Committee. So the idea is to transition this committee of our community into the Continuum of Care so that they can take over this housing project.
Really good.
Yeah.
Has there been a site projected?
Yeah.
Because I have all this information. Where's that site going to be?
We can't disclose the site.
Yeah, it's not disclosed, but an offer has been made.
Yeah. Because, you know, what their experience is, as soon as you identify a site, then it creates concern or anxiety, and that might not be ultimately the site that is chosen. So they're keeping that information pretty close to the vest.
That's fine.
But we're just really excited about the partnership. Greater Columbia did apply for the ACH grant that was available. We did not receive it, but Wes and I learned a ton about permanent supportive housing in the process, and worked with some great partners, CADLAC, CAC, Catholic Charities, and LORDS. And I think that, you know, hopefully, if we're successful, they will break ground in March or April of 2020. So it's possible. Just keep your fingers crossed.
Okay. Good.
Becky, do you want to talk about the dashboard?
Sure. The financial
district?
executive portal?
Sure.
So, thank you, ladies. So up on the screen, you can see our financial tracker, I guess if you want to call it. It's our little spreadsheet that shows how much money that we have spent from the financial executive portal. And as you know, all of those funds have been contracted mostly to our PCMH providers. There's also the IMC money in there for our new cohort 2 behavioral health providers. And we're just finishing up the quarter 2 payment for the cohort 1, which has been a big one. And navigators will tell you, and all of you guys that worked in the workbook, this second set of reporting was big. There was a lot that went into that. And so it's taken us a little bit to get all the payments out because navigators and Sam have to go through and look at all the hard work that you guys put into the portal and the reporting and score it. So we have 2 more payments that need to go out to one of our providers, and then we'll be done with quarter 2 payments. So nice work, you guys.
Good.
So you can see on that spreadsheet that we have our total payments for 2019 out of the portal are up to $9.6 million. So we're super excited about that. We have a lot more to go. We have a lot more money that's contracted for the remainder of the year. And I think everyone's really doing a lot of hard work to accomplish their milestones and so they can get paid. So thank you all for that. Yeah.
Good. That's good. Thank you.
I know that we have our guest from Myers and Stockbridge today, so I thought I would just cover briefly about workforce because this is another area that Greater Columbia is really fortunate to have Dan Ferguson on our board of directors. Dan, you know, is a subject matter expert in workforce, and we had a great meeting, I think it was last week, talking about the policy and standards a part of that. The policy, after months and months of looking at data and analyzing where we really need to be, and as you know, the board of directors set aside $490,000
out of the IMC funding for behavioral health workforce to address behavioral health workforce shortages. That seemed to rise to the top after all of the analysis that we had done, surveys and letters of interest and current state assessments. Behavioral health really rose to the top. So we had to focus in on, so what is it about workforce that we're going to fund? And we came up with an idea of funding internships and preceptorships and possibly peer counselors and community health workers. So we're still in the throes of finalizing that policy, but we've made some great, I think, leaps in terms of landing within the provider offices, since they would be the ones that are precepting, and it takes time away from their work interning or precepting students. So this is kind of where we're landing. We'll have another meeting to finalize the second half of that policy, but this is as far as we've kind of gotten with how to increase the capacity of our providers through providing internships and preceptorships. Interestingly enough, Martine and I attended the Pullman Innovation Summit on Tuesday, and they were talking about the very same thing, is that one of the barriers to building capacity is having the faculty and the internship paid for, because it costs a lot of money for providers to intern. It takes time away from their day. So we think that we're on the right track, but hopefully we'll be able to bring that finalized policy back to the board next month for approval, because we would like to get these dollars into the hands of the providers as soon as possible. I think the other thing we realized is $490,000 is probably not going to go as far as we had originally thought.
Never does. Sounds like a lot.
Sandra or Linda, do you want to add anything else?
Well, we were just talking about the money portion of it. We did have a pretty lengthy discussion about that and the need to offer incentives and increase capacity with our provider partners, but also making sure that we're realistic with that we can offset the total cost of these opportunities. And so it'll, it's going to take a little bit of work, but I think as long as there is an incentive to the providers for taking on these initiatives, they're going to realize that the reduced costs that they may potentially have to pay in recruiting for these folks when they're done with their internships might be the offset that they're looking for to help us stretch these dollars out a little bit further.
Do you want to add anything more?
I just think it's the discussion brought up lots of points, and I think we moved forward well.
Yeah.
The one you sent out later was very clean.
Yeah, that makes sense. We use that at work all the time. The idea of growing your own people to help you grow and accelerate what you're doing already.
Yep.
Makes a big difference.
You cannot defer all costs. I mean, it's just you can't. So you have to just say, we'll help share the pain of doing this, and hopefully make it worth your time.
Medicare does it with medical schools.
Yeah.
I mean, it's a well-known fact.
Well, there was a third-year resident student that kind of gave a testimony, and he put up a picture of his 4-month-old daughter. She's a coug, and she's just a coug here. But he said, by the time I'm done with my residency program, Rachel will be 7 years old. He goes, I don't want to disrupt her life. I don't want to move her out of the community. I don't want to move her out of her school. And he said, so this is why growing your own makes so much sense, is because your residents want to stay in the community where they have been doing their practices and their practicum. So that was the first really concrete example I thought of. Yeah, that's why it works, is because these people become a part of your community. So it's really important for us to embrace them and bring them in.
That's a great point. I was 9 when my dad started his practice. We moved from DC to Florida for his first job. We didn't get to stay. But that's exactly what happened.
Right.
That's exactly what happened.
Sam or Diane, did you guys want to talk about the learning collaborative schedule just really briefly in Ken Crable and some upcoming learning collaborative opportunities?
Go ahead. Okay, so we actually have our learning collaborative through the rest of the year, and then a couple for January and February for the behavioral health providers already scheduled. One of our biggest, we have two really good ones coming up. One is in November, which is Ken Crable. He's going to present on trauma-informed care in November. Most of our staff went and listened to him do a presentation in Yakima, and he is phenomenal.
Yeah.
He does a really good job. And I think that everybody who attends will be able to understand more about trauma-informed care. And then in December, we are bringing in Adam Falcone from New York. He's well known for managed care contracting. And so he's going to come and help the providers know what kind of things to talk about and to be able to help them negotiate some of their contracts that will be coming up again for the next year.
He's really good. He's been practicing with Phillips and Tucker Life for Fidel for many, many years and has done a lot of presentations on basically all the FQHCs, utilized his expertise.
Yeah, we've extended it out to all of our providers so that if anybody other than not just the behavioral health providers are welcome to come. We have heard really good things about him as well.
Really good.
We have talked about, providing maybe something in the future, like about how we can kind of help providers individually. So we'll talk about that more as we find out how providers thought he did. And then for January and February, we have the crisis providers in each of the areas that they're going to kind of give a deeper dive in best practices and things like that. So the next couple in January and February, that's what the focus will be. And then Sam and I are going to work on next year's learning collaborative for the next year and what that looks like.
And November is going to be really interesting as well. We have someone from Western University that's coming in, and they're talking about high school students that are interested in healthcare education and how we can actually implement or scholarship them different or to drive them towards healthcare that specifically in areas that we have a deficiency in. So it'll be a really good topic.
Okay.
So, Ruben, do you want to talk a little bit about the community resiliency campaign, and then I think that would be it for our report.
Yeah, certainly. For the last couple of months, our task force for the community resiliency campaign, we've been looking into a lot of data, getting a lot of recommendations, a lot of directions from them. And recently, we decided to conduct a pilot in Yakima. So that was followed by a summit with local leaders in Yakima for them to help us collect some information, give us some input on what the resiliency campaign message should be. And we conducted an activity, the community cafe, to harvest that input. Later on, a smaller group got together to distill that information, to see what kind of message they really are telling us to send out there. And this is a community resilience campaign. The message is going to be more towards systems, early childhood education, foster care parent systems. Obviously, it's going to be a media campaign, and it's also going to be for the general public. But part of the campaign is also going to be more targeted. We're going to have speakers, we're going to have trainers, and we're going to bring them so they can talk directly to early childhood education professionals and foster parents. And the media campaign is going to be pretty much providing offer for that. So we have completed that process, and we have arrived to the staff and this smaller group. Where is it? Okay, there it is. So we came up with this, the bottom of the first paragraph. We thought that's what these leaders are telling us the message should be. Kind of like if you want to maybe a tagline or some kind of tagline. So we're going to take this to we issued an RFP already to find an ad agency or a media consultant to help us put together the entire campaign, like a one-stop shop for them to organize this campaign. So we're going to take this to them. We're going to take all the raw data that we collected from the summit. So we came up with this message. Resilient communities raise resilient children. Build resilience, play, laugh, love, protect. And the reason we pick play, love, laugh, love, protect, because these general categories were coming up over and over on how to build resiliency or how to create resiliency within your family, within your community. So we're going to take this to the media companies that we end up hiring along with the raw data that we collected. And they're going to run with it. Obviously, there's going to be that back and forth where they whatever the proposal is capturing the essence of what we want to do. But that's what, and then for those of you who are new here, this is to address or to mitigate the effects of adverse experiences, which the study has shown that the more adverse experiences you have as a child, the more likely you are to have several chronic conditions later on as an adult, more attempts to commit suicide or complete suicide. I'm sorry, you don't say commit suicide anymore, you say complete. So that's what we're trying to do here. We want to focus on resiliency. We want to bring the message to the community that we need to protect our children, that we need to build resiliency within our communities and within our families to mitigate the effects of this adverse childhood experience.
Thanks, Ruben.
Yeah.
Actually, Brian, I have had a request by Les to find out what the date of our open house is.
Well, I'm glad you asked that, because I was going to tell you all, and I admitted that very important piece of information to my
I thought
update.
you guys could read our minds.
Yeah.
Whatever you want.
I think when these articles were due, we hadn't decided yet, so I think that was why, so I apologize for that. October 25th. Write it down there.
And more information will be coming out on that as well.
Is there going to be a Halloween thing?
Every day.
Yeah, every day.
I'll be ready this afternoon.
Every afternoon, you're welcome.
Come trick or treat at our house on the 25th.
Plan on it.
Thanks.
I have one more article too I'd like to highlight, Carol, if that's okay with you. I'd like to
yeah.
welcome Chelsea Chapman as our Welcome. Chelsea joins us as a former innovation consultant. She's trained in trends analysis, disruptive market research, and enjoys event coordinating. She will be taking over managing and organizing meetings, taking minutes, and supporting the directors as needed. So welcome.
Thanks, everybody.
Good, thank you. That's great. Anything else in here, Carol? Okay, thank you very much. So we'll move on to the action items, the things that are coming up that we have stuff to do. So last week, Becky and I and all the rest of you guys, I think, and Jorge was on the phone, wasn't he?
Yes.
Do you remember anybody else was on that? I think it was just Jorge and I.
Right.
And you guys. We had the opportunity to go through the August financial reports, and of course, I was hustling on my way out the door this afternoon, and I forgot all my little notes that I'd written down.
Oh, that's
They're sitting on the paper in front of my computer. I know exactly where they are. If that means anything to anybody. They were brilliant.
Your notes, yes.
Yes,
I'm sure.
my notes were brilliant, I promise.
I'm sure.
So we did go through the balance sheet, the income statement in detail. Becky always does present a line item detailed report outlining things such as how much money we spent for office supplies and how much money we spent for a prepaid credit card and gasoline and all that stuff. And so there were no surprises in there. My recollection was you had a couple of things that you needed or that you were working with the accounting office, the bookkeeping office, to change relative to payroll and accrued benefits.
Yes.
We're moving from a cash basis to an accrual basis accounting, and that's been going on for a couple of months, and we're starting to see that finally come together.
We are.
And it's starting to stitch together and tie effectively. I always have a couple of key places I look at make sure that the balance sheet matches and that I can track it back to the financial statements. So all that stuff's there, and it looks just like it's supposed to.
Yes.
Were there other points that you had in the discussions that we had the other day?
There were a few
There was
things
something
on
that we
there.
wanted to get approved.
Yeah,
too,
there. No, we've already approved everything. Yeah, no, the other item that we discussed was there were some, deferred revenues that our auditor put on
right.
and they, unfortunately put that in our books and didn't talk to me.
Right.
And they have been, we're working on the RFP. They've been super unresponsive to me the last couple of weeks, and I'm not very happy with them.
That's right. I wasn't very nice about that either, as I
Yeah,
recall.
fully closed on that. So the RFP is, we're working on that. I've got it's drafted. Carol and I are making some tweaks to it, and we're going to get it out. They've changed a lot of their staff over. So we lost our manager that we've had for years. It's been awesome. We lost our accountant that we really, really liked. And the new staff that have come on are just not as responsive as the old staff were.
And it doesn't sound like they did a very good handoff either.
No,
they give you the information.
They did a very poor handoff. They still haven't finished our audit from 2018. So we're not.
Yeah.
We're going to be moving on.
Yeah, that's what we got to do. So
there are some things in the financials that if you guys have questions, please ask me. As Brian said, we discussed it at the finance committee meeting. Just for time's sake, I'm not going to go into it here. But what we usually go over during this meeting is our budget versus finance actuals, which is up on the screen there, and that shows you year to date what we've expensed for some of our higher level categories of payroll, contract services, professional services, our facilities, which as you all approved, our move is going to be well spent in the next month as we move into our new building. Our staff training expenses are on there. We still have some categories that we haven't expensed against, which is one of them is our grant writing that we put in the budget for this year. Everything else is getting some expenditures on there. As Ruben mentioned, we've gotten some loan payments out, so that budget is being expensed. We've been doing a lot of learning collaboratives, and so that is going down. And as Carol mentioned, there's $490,000 in that budget that is for the internships that we're working on getting those fundings out as well. So that is the operating expenses. And then if you want to switch over real quick, Lauren, to disrupt this, looks like this one didn't get printed, but you guys have it in your electronic version. So this shows just a little more detail about what I talked about in the report for the money that is in the district that is getting expensed out for our project areas that you can see on there. And then of course the beautiful pie chart that Rachel puts together per request of our board president. It kind of shows you a visual of the money and where it's going and how it's been spent so far this year.
We in the finance committee, we only had the two of us, so we could not prove things. We were going to advance the recommendation to the board to go ahead and approve these financial statements, having gone through them in the detail that we went the other day.
Yes.
So we would need a motion and a second here to enable that.
Yeah, I motion that we approve the budget as presented.
I'll second that.
Okay.
Everybody wants to jump
on. Any other comments or questions?
Yeah, please, if you guys have any questions as you go through, there are some things in there that are a little different than what you're used to seeing because of what we're going through with our accountant. Accountantship and transition. Our transition.
Okay, no other comments or questions. Those in favor?
Aye.
Any opposed? Very good, thank you.
Thank you, guys.
Next thing we had on here was a discussion about the October 30 Provider Recognition Awards.
So
a little
many
get
of you,
together, right?
I'm sure, are aware. I sent out the invitation. We are hosting the Provider Recognition Awards on October 30th. It's similar to the event we had last year. We'll be inviting Cohort 1, Cohort 2, Cohort 3, the Opioid Resource Network managers, and Local Health Improvement Network leaders, among other partners.
And the board, right?
And the board, of course. I'm sure many of you have already received the invitation. We're really excited about this event. This event will give us a chance to highlight practice transformation, all the difficult work that our providers are doing, whether it be attending learning collaboratives, achieving milestones, mini reporting, meeting with the navigators, the list goes on. This is really a chance for us to recognize our providers and how appreciative we are for all the work that's being done. The event will be located at Walter Floor Wine and Culinary Center, similar to last year. It will take place from 5:30 to 8:30. We'll have John Gilbert presenting on motivational interviewing. We'll have some awards that our navigators are putting together. No host bars, no host bar, if I can say that.
Oh,
Sorry, but it will be there. Dinner, and then entertainment by Curtis Nettles, who was our entertainment last year as well. He was great.
He was.
He was
wonderful.
I great.
enjoyed
I think you danced with him,
I
right?
did. If you guys ever need somebody to rise to a challenge and no barriers, I'm willing to entertain.
So the analysis portion talks about our budget. We're asking to allocate $20,000 to this event. That will include awards and gifts, catering, decorations, entertainment, marketing, speaker fees, and then the venue charge. We'll be taking this dollar amount out of the contract services budget. After the completion of the event, if we were to spend all $20,000, the contract services budget will have $135,121.72 remaining. So our recommendation is GCACH staff recommends that the board authorize the $20,000 proposed budget for Greater Columbia Accountable Community of Health to host the October Provider Recognition Awards event as outlined in the SBAR. And I also wanted to note that this has been approved by the Finance Committee.
Right. Finance Committee looked at this and we knew where the money was and were able to accommodate this request. So that's good. Thank you. Discussions, comments, thoughts, concerns.
You guys didn't put anything in here just in case something comes up? That's the only question I would have, because in doing events before, there's always something that comes up, so you didn't put a little thing in there for
contingency.
Oh, contingency.
Well, you could say that the speaker fee, I mean, we could take that speaker fee out of the learning collaborative fund, so I mean, if anything, we can
change that to a contingency, because that's what we decided that we were gonna take out of the learning
And we could also take the marketing and decorations out of marketing budget. There's quite a
so there's some areas that we can.
You can flex.
Yeah.
Yeah. Okay, yeah, because there's always something that comes up. We didn't get this, or we didn't pay for that. And so I would.
Having it all here gives us a clear idea of what expected expenses are.
Yeah, and $20,000 really is cheap. I don't know about you guys,
It's
but
doubled from last year, and I think it's because we're inviting a lot more people this year because we have more providers this year.
Right, but having the amount of people that we're involving in this event, that really is a cheap amount, and you guys are doing an excellent job. If you can do it for that budget, I'm like on board. I would assume that it would be upwards of 28 to 30 for the amount of people that would be showing.
We just have a really good person who knows how to do good stuff.
Well, I think it's wonderful.
Nothing on a budget.
The dollar store, right?
I haven't seen him for Brian, I think we got one.
So yes, would that be a motion to?
I am going to, I'm going to put out there that I motion that this amount be accepted as the budget for the event for our providers.
Thank you. Second.
I'll second that.
Very good. Any other comments?
You guys better come.
See you all there.
Do I get to bring a date?
Yeah.
Okay.
One of us might be on an airplane to a wedding.
I'll put in for a second.
I'll send a representative. Representative. Representative.
I got somebody that can play
That's what we have to hear.
Brian,
Yeah.
for you.
Actually, that should be part of the decoration. We'll just have a little title with his face on it, like this big.
It's possible that I might be more interested in being here than going to.
Oh, no.
You lie.
I can't believe I have a kid getting married. Okay.
Call a vote.
Oh, we got to call a vote. Thank you. All those in favor?
Aye.
Any opposed? Thank you very much. Motion carries.
Lauren, you want to mention the Eventbrite real fast?
Sure. So within your packet, you'll see that I included just a copy of the invitation. At the bottom, let me pull it up for you. There's a link to the Eventbrite, and that's where we're asking everyone to register. If you could please register each person, that gives us an accurate count for catering. Like if, for instance, we are allowing 3 to 4 people per organization to attend, so if you could just register Sandra, Brian, and Courtney, that would be great. We would really appreciate that, so we have an accurate count. There's also information on there for hotel accommodations. We realize that several of you may be traveling from out of town, so we have a room block at the Prosser or Inn or something like that. The information's on the Eventbrite. So if you have any questions, feel free to reach out to myself or any of the GCACH teams.
Very good. Thank you. Next item you have on here, Carol, is an approval of cohort 3 for you and Sam, correct?
Sam, do you want to take the lead on that one?
Thank you, Lauren.
So the situation is Greater Columbia ACH, so we sent out letters of interest and current state assessments. I'm sure that most of you guys are familiar with that big document with lots of questions that are wrapped around the change concept. Of the 29 organizations, 3 were hospitals, Trios, Whitman, and Tri-State, and 7 were skilled nursing facilities or operated palliative care programs. From the 29, GCACH received 5 submissions, including 1 hospital trio. GCACH contracted with OHSU, as we did with our previous cohort 1, to provide an independent evaluation of submissions, and 4 were identified for the PCMH program. The executive director, deputy director, and the director of practice transformation have repeatedly reached out to the balance of the provider organizations, and while many organizations are interested in the program, they need more time to determine whether or not to enter this program. Carol and I and Wes have identified many of the organizations were going through transitions of leadership where they just didn't have the capacity right now to be able to do that. The background is the patient-centered medical home is strategic foundation for Greater Columbia ACH approach to transforming the region's healthcare delivery system. Developed from the chronic care model developed by Ed Wagner, MD, director of the McCall Institute for Healthcare Innovation. The PCMH model acts as an umbrella to incorporate the evidence-based approach from the Medicaid Transformation Project Toolkit and Greater Columbia ACH core project area. PCMH model of care is a strategic way to strengthen primary care, improve reimbursement services, and will help providers be successful in value-based payment contracts, such as provide sustainability beyond the life of the Medicaid waiver. Since adopting the PCMH model of care, Greater Columbia has provided technical assistance to 62 clinics, hospitals, a dental office, and behavioral health providers, one of those being in urgent care as well. The first cohort included 45 sites that targeted hospitals and clinics. The second cohort included 17 behavioral health organizations that transitioned to integrated managed care in January 2019. The third cohort received approval from the Board of Directors at their July 18th meeting to add 20 more organizations, some of which were skilled nursing facilities. Analysis, while site visits and comments originating from the provider organizations have placed PCMH in a very positive light, some of the provider organizations that GCACH reached out to have not been engaged in NTD work. On the back of the form of your SBAR, the following the previous process for cohort 1, the organizations were scored based upon the LOI CSA questions related to the change concepts with weighted values. Out of those 4, the recommendation is staff is recommending that the board approve the top 4 organizations that submitted LOI CSAs and were scored high enough by OHSU and the Director of Practice Transformation to achieve success under the model. Garden Village being the highest, RCCH, Trios, Ideal Options, Chaplain City Healthcare. They also recommended that the board allow a rolling application period through the end of 2019 to allow enough time to make presentations to organizations unfamiliar with the MTP and the PCMH model.
Okay. All right, so you have a recommendation from staff to advance these 4 or 5?
4.
5.
4.
4 out of the 5.
4 of the 5.
So that would be Garden Village, RCCH, Trios HC, Ideal Options, and Chaplain.
The Quality Care Medical Clinic, after scoring it, it had actually scored the lowest out of any of our organizations in cohort 1 and cohort 2. So that's why my recommendation is a no for that.
Well, even OHSU recommended those. They,
So are we,
So let's do a motion first, and then we'll talk about it somehow. So we're gonna do.
yeah, but I have a question about this.
Oh, then go ahead.
So on the 5th one, if we're not including them in this motion, are we saying they're not going to be, or are they going to have until the end of the year to maybe redo what they are submitting and be in a different position? What happens with them?
Their submittal was actually efficient enough, and they answered all the questions. It's just
They're just not a good partner. Okay.
they just don't have leadership buy-in, and there's some other reasons. They're just
well, actually, leadership was high, but they didn't have any of the other qualities for the values weighted. Were very, very low. The only one that they actually had buy-in was leadership.
Just trying to make sure I understand what's going in this motion,
Well,
Brian.
I think that's fair.
There's 7% there, but everything else is 2% or under, or 3% or under.
and it's lower than any of the
Yeah.
even.
Right, I just wasn't sure why it was so low, and so, and what's the impact of this motion ongoing for them? So,
I mean, they could definitely, no, actually, this might be our last cohort with, no, they will not be.
yeah, I just, like, no.
It's
Right.
no.
I was just, hey, I'm looking out for other provider friends here in this world, because it's rough life out there. I just wanted to make sure that we understood what that means for them, and whether or not what their options were. Is it that they really just aren't a good partner, or is they're just not there yet, and they need to be like some of these other partners that are maybe not super active or unsure, and they need more time? So I just wanted to have a clear understanding of that
With
before.
the revenue cycle the way it is, we would not have enough funds to be able to support them in the transition.
So just to add a little bit to this, all those other individual organizations were sent to us by referral or previous relationship. Quality Care was a last-minute organization that personally I put on with another provider because they were on the list of, we did an analysis of Medicaid claims to see which organizations had the highest, and they were really farther down the list. So just to fill that list out with additional clinics, they were a real late add-on. So they weren't referred to us by any other organization.
Okay. Thank you. It's an excellent question.
Thanks.
Okay, so we need a motion.
I'll make a motion that we accept the staff's recommendation to add these 4 organizations into the cohort.
Second.
Very good.
And the rolling?
Yeah, we had a rolling
Okay,
conversation about the rolling.
I just said your recommendation. That is your recommendation.
There it is.
Putting everything in the box.
Yes, the box. That's why we put the box. And there's the board allowed.
I will work this.
I said the staff's recommendation, that's the box.
Yeah.
Okay,
So,
all right, so I will make a motion to accept the staff's recommendation.
And
I
the
just say
rolling.
as read.
Yeah.
As written.
So you have a motion, you have a second. Do we have additional comments, conversation, discussion in here?
Andrew, do you want to talk about what happened yesterday in our conversation with Carlos, or?
I don't know that changes anything with this.
Okay.
That's, I think, future years. And that was just to look at the scoring criteria, the selection criteria, and looking at does the weighting still play as we go down the road? There was, there's a thought that this first year we spent a lot of time building up organizations to get everyone kind of on the equal footing and level playing field. But then at the other end of it, there's a lot of organizations that have sites that are serving large number of Medicaid lives, so that volume comes into question. And what are we doing to offset them and actually get support out to more sites and locations, because there is a volume issue. We have the way we set out to give with a maximum of 2 sites per provider,
Right.
there's a lot more sites out there that could probably benefit from additional funding and support and help us reach more lives in the Medicaid transformation process. That would be included in our reporting and whatnot. So it's just more of a look at the weighting, but I don't think that changes adding these providers to cohort 3.
Well, I guess I would just throw it out that, what Carla said really has a large impact on me, and that we have, even though we have weighted volume fairly low through the practice transformation work group, there still needs to be recognition for those providers that are providing a lot of services to the large number of Medicaid lives, and just maybe a discussion for the board in the future to say how do we level that up for those really large providers. So I just want to be transparent about these other conversations that are happening, because I think it's important for the board to understand that there's lots of different points of view about how we allocate the funds, and we certainly want to be providing support to our largest Medicaid providers.
It is an interesting comment, though, because we've actually had the same conversation internally at our organization. It's the same thing. You got 2 sites being supported, but there's 38 sites.
Right.
And and so yes, there's some seeding, and then it grows from there. But there's a lot of other stuff that happens. And I think Carlos is right.
Right, and then there's also if we
and everybody's got different levels of that, right?
And
some folks are further down the road.
Right, and I guess if we have a cohort 3 that we don't fill because of that,
right,
I think through no lack of effort on staff's part, are providers not engaging. I know you guys are on the road. We see every week how many different outreach projects you all have. Let me tell you, sometimes I'm exhausted reading the email that Lauren sends out, so I don't know how you all are doing it, but there are some providers who either are never going to be ready or who just don't want to engage.
Exactly.
So how do we fill in the rest of these slots? And maybe that's part of the conversation too. What do we do when we don't fill these slots? How do we count? Is there an opportunity to go back and look at the volume again and the scoring? Yeah.
Well, there should be enough funding if we just don't add as many funding. We asked for 20 the last time for the budget. So if this is only 8, then the funding may be there.
The only thing that I get concerned about when I hear this and I see this kind of stuff is the actual end game where consumer walks through the door and is knocking on that door, and though there's low numbers over there, are they getting the quality service? And when I know that there's so many people that fall through the cracks, that's how I see this, is there's holes in the floor, and we can't support the whole floor without it, without moving something around, and another piece is going to crash. But how can there be a collaboration to help support those clients or those consumers that are going to enter through this door and may not be receiving the same quality benefits as another provider that provides more assistance to more numbers? And that's where I get concerned, because when you're talking about a small town USA, they walk in for services and they're told they don't provide that service, can't provide that service, you'll have to go elsewhere. And then we have transportation issues. Then we have financial issues. And it becomes very difficult for those people to get the care, and then they become the high utilizer because they can't get the care. So those are my concerns when I hear things like this. It's not that I don't think that it's right or I think it's wrong, because we're doing the best that we can with what we've got. But I still get concerned there. And how can we pick up those numbers to be in a collaboration of something? If they're getting the money over here, how can that be extended to help support, even if they're not ready on this end? How can we get these organizations to work together to support one another in more of a spiderweb form? Even all along that we've been doing this stuff, those have been my ongoing concerns, because we've had to leave people out.
So I think one of the futures, right, that we did we did a retreat, summer, end of the summer, or end of the spring, right?
Beginning of spring.
Was the future of the organization after the money runs out, how do we advance? And I think my recollection of where we kind of ended up, Ronnie, to your point, is at that point, you got a house full of experts on how to advance existing services or new companies, new providers along this path, albeit on a different time frame, or perhaps after, maybe they're not early adopters, they're mid adopters, maybe they're late adopters, in an effort to actually drive that transformation through into the community. I think that's where those opportunities come up. So they may not be ready now, but that doesn't mean that it's over. I think the challenge becomes one of capital support coming in from the state or whatever. But again, the role that we all envision the ACH providing is one of scaled up resources that should be able to be provided for less expense for those companies trying to create this stuff. So yeah, I hear what you're saying, but I think one of the things that came out of the future of the ACH is an effort to try to ensure that there's an ability to capture that later.
Yeah.
If they're not ready now, you may be ready later, and we'll be here for you then too.
Yeah.
That's kind of what I saw as the mission coming out of that group of meetings.
And there is something to be said about, okay, if we keep knocking on your door and you're not answering our door, and the patients keep knocking on your door and you're not answering the door for them either, what are the providers who are engaged going to do that? And I think you have to recognize the providers who consistently go above and beyond and keep expanding access, keep expanding access. And so,
agree.
So it's just always a balance. There's no right or wrong. I mean, I agree. We can't forget those people either. And I don't think it's from a lack of effort that we are forgetting anyone. And
I don't think that it's purposeful, and I'm not pointing fingers and blaming and shaming, because that's not.
No, and I don't think you are. I just think some providers have said, I can't deal with this right now, and they're not engaging. It's not, and so
and
we
I
have
get
to respect that.
I get it, but it's not so much that as that I get concerned over the consumer needs.
Right.
More than I'm worried about if a provider is saying, I can't do this, I can't do that, where does the consumer go? And who do they reach out to? And it's just something that's consistently gone on for years and years, and it's not going to change. I think that there's always going to be somebody that falls through the cracks, but narrowing those holes.
And that's been the benefit of this year, where we've kind of uplifted everyone and got them off that same playing field, because everyone has been able to take on more access and capacity to help those consumers.
Right.
So that's kind of where it's been there, and I think we've been focusing on that.
In addition to encourage those collaborations.
Those are the pieces that I'm looking at, is the collaboration.
Yeah, these organizations that are participating providers have an agreement or a milestone setting to actually reach out to their natural resources, or for us to build those collaborations and agree on other areas that they might, or services that they might.
And this is where I see the MCOs coming in to support those consumers that are struggling in those areas, that haven't been able to move forward with the transformation, but getting them supported somehow through more or less a collaborative with those that are, and trying to make those connections. Because I know that there's a way to get the consumers supported in their communities. But I think that when you have consumers so used to business as usual and not understanding what at this level we're doing on their behalf, and not understanding what resources they have available because they just have a medical card that says that they can go get services, but they don't know what those services are available to them, and getting those things done, and then having those outreach pieces. I mean, I just get concerned because I've seen it over and over again, and when I see this right here and they're not coming over and they're not saying, yes, we will, I'm looking at they're serving consumers, and where are those consumers going to get the assistance that they need.
So Ronnie, I appreciate, you're looking after the consumer. That's your representation, right? And that's really important. I think part of our sustainability plan was promoting Lauren to be the marketing manager so that we could do exactly what you're saying, is that we can get into those provider organizations with data and with analytics to show them this is what has happened to the other cohorts. Look at the services that they're being able to provide. Look at the quality that has been promoted using best practices and, risk stratification, really understanding their patient population. So I think for a lot of providers, it's just been that lack of hard data that they can see, how is this investment going to benefit me? So that's part of our strategy, I think, as we move along this continuum, is we will be able to better sell some of the reticent providers by the evidence from the first year. Think about, we're only halfway through the year, the first year of implementation, so we don't have as much to sell right now. But I think by the end of the year, we're going to have a different story, and we'll be able to reach some of those providers that were reluctant or didn't really understand a lot about what does it mean to be a patient-centered medical home or have the tenets of a PCMH organization.
We talked about that yesterday as well in the midpoint assessment. What story do we really want to tell in order to have all providers on the same playing field as far as the definition of what the ACH is doing? And a lot of that does come down to we still need to have data in place. We only do have 2 quarters in. But look where we'll be in another quarter. We'll have, I'm waiting for Wes to bring me a Christmas tree or something. When it comes to data.
You're Santa Claus. Bring the good.
Yeah, so, but it does take time.
Yeah, we're working on it. And, like Carol said, we're pretty new to this. I mean, we're pretty early in the implementation. 2 quarters, a little hard to tell about how much change each organization is going through, but we want to produce more data for the board to see the outcomes.
Okay. I think the other thing that we've learned in this pursuit is we tried to get some university organizations on, so like Cougar Care. So when Martine and I were in Pullman the other day, we met the medical director. Well, it's not that they don't want to do PCMH. In fact, she's very familiar with their medical director is very familiar with PCMH. But a university institution is very different. She said the funding doesn't come through fee for service; they get it through their university. So just because you contract for patient-centered medical home or PCMH or practice transformation, that funding might not go to the clinic. It might go to the university. So we are learning a lot about going into these different market areas. Skilled nursing facilities, again, they have to have approval from their corporate offices. So I don't think that we gave ourselves enough time or we did enough marketing in advance to some of these new organizations to convince them that this is a great thing for them. So hopefully by the end of the year, we'll be able to add some more organizations, but I would think that this would be a really good conversation at the end of the year or the beginning of next year. If there are organizations that we have not added, I think we should circle back and talk about that volume piece again. I think that that's really important.
Thank you.
Okay, so we have a motion and a second on the table. Other thoughts? Okay, all those in favor of advancing these 4 providers in the cohort 3?
And rolling up.
Oh, and the rolling 12 months. Thank you. Any opposed? Okay, motion carries. Thank you. Thank you all. All right, so do we have any other action items that we need to bring before the board today, Carol?
No, just some presentations, I guess.
Excellent. So the next thing you have on here is the semi-annual report presentation.
So this is something we've talked about before. I'm going to go through this really quickly because this is kind of water under the bridge. The end of the first reporting period happened at the end of June. Next slide. Go through this real quick. So we're required by Healthy Washington Medicaid Transformation, Special Terms and Conditions, to do semi-annual reports. The independent assessor, who is contracted by Healthcare Authority, who's Myers and Stauffer, who's here with us today. Next slide. So this is what the timing looks like. We're at report period 3. We're going to go through report period 8. 2 semi-annual reports per year. We just completed 3. Next slide. I'm going to go through these really quick. There's a lot of familiar topical areas. The new ones are quality improvement strategy and pay for reporting. Carol's going to talk a little bit about quality improvement here in a minute. Let's go on to the next slide. So after the SAR was turned in, the independent assessor came back at us and gave us the benefit of a write-back process where we could address some areas that they had some questions on and complete some things that were left unchecked. So the biggest piece here was the updated implementation plan. Probably 80–90% of our time was spent going through this, and we go through this process every single semi-annual report. And we always think it's going to be quick and easy, but it's just so time-consuming. These documents are big, they're complex, but each time we go through, we feel real comfortable that we've done some positive improvements. It helps us better understand the work that's involved, and that's the next slide. So, real briefly, paper reporting. This is a new piece. This was completed through some internal analysis that came off of the MEHAPs. It came out of the toolkit in the reporting portal. There was also a small survey that was sent out to community-based organizations that were tied to the ORN. And next is the quality improvement strategy. Before I turn this over to Carol to let her talk about it, if you could go forward 2 slides, one more. I want to talk a little bit about the upcoming SAR. For SAR 4.0, there's a couple of new areas on here that I thought were real interesting. One of them is this bullet number 3, mechanisms that have been, this is what their expectation of reporting is, mechanisms that have been established for coordinating care management and or transitional care plans with related community-based services and supports, such as those provided through supported housing programs. So they're looking for a connection between what we're doing and the social determinants of health. Sam briefly talked about the toolkit calls that out as a requirement, extending into what they call the medical neighborhood, which includes specialty providers. It also includes social determinant providers. Next slide. Next slide. Finally, there's going to be a big piece on reporting about value-based payment. For those individuals who attended the Leadership Council today, we had a really great presentation from Healthcare Authority and a very nice panel discussion that talked about that. So we're trying to do the requirements for meeting that. If you go back 3 slides, one more. So Healthcare Authority gave us a template for a quality improvement strategy. This was a separate document, separate from the SAR, that we included with the package that was uploaded to Healthcare Authority. And I'm going to let Carol talk about that.
So we have talked a lot about patient-centered medical home because it really is a foundational strategy for Greater Columbia, and it really is a quality improvement process. I think somebody at the Leadership Council meeting said very well today, the journey of practice, it's a journey of practice transformation. So it just doesn't happen all at once, and that really is about process improvement. And that, to reiterate what Wes said, it is actually been kind of, well, it is hard, but it's been kind of fun going through the implementation plan to understand how far we have really come, and then where we have already made improvements to our process. So this quality improvement plan really just extracted out of our implementation plan the number of steps that we're taking to, number 1, implement practice transformation and how we are developing our cohorts. So if you just want to take a look at, I think they all got one, right? In the first page, it just says, so what are we doing to develop continuous quality improvement strategies, measures, and targets? And again, we just say that Greater Columbia is using PCMH.
No, I didn't print it, no.
Oh.
But it's, sorry, that's confusing. It's in the board packet online.
I will quickly walk us through this, because there are many pages. But basically, we're using PCMH as our framework for quality improvement. But it's not just PCMH, it's the technical assistance that's provided by the navigators. And it was interesting that J.D. Fisher this morning said that the most effective quality improvement strategies deal with one-on-one technical assistance. And so there was a row of smiling faces at the Leadership Council meeting today, because we're really proud of our navigators and our practice transformation team, because they provide that one-on-one technical assistance. So that's part of our improvement strategy. And then they keep track of each organization through what's called the Practice Transformation Implementation Workbook. And as they meet with the organizations, they write down the barriers and the possible solutions, and they keep track of that so that the next time that they go back to that organization, they ask, so how are you doing that area? And they can keep track of the processes and the improvements, the workflows, and all the other business things that have to happen. So at the very bottom of the page, we just talk about that the model really entails numerous changes to a practice. It's everywhere from claims and billing improvements to workflows and schedules. I know that they're spending a lot of time looking at EHR and AHR improvements, triggering certain functions that the organizations didn't even know that they had. So that's all a part of that practice transformation technical assistance. And then we've talked a lot about our learning collaboratives, and that really is another way to help our providers understand better, why should we be doing bidirectional integration? What are the advantages of using the Interact model or the Boost tool? And so we bring together all these subject matter experts. The board was generous enough to allocate $100,000 of our design funds to practice transformation for cohort 1, and then, as you know, we took $100,000 out of cohort 2 IMC funding to provide those learning collaboratives. So we are spending a significant amount in trying to provide outside subject expertise to support those 4 project areas. The providers work from a kind of a structured workbook called the reporting workbook that has been assisted by the practice transformation navigators who allow the providers to kind of design and implement their own programs as part of that quality improvement. And then finally, we have the process that's overseen by the practice transformation work group, and this is a chartered committee of the board. So you might remember last year the board authorized this committee that's comprised of primarily clinicians, physicians, nurses, quality improvement experts, and we have our workforce subject matter expert, Dan Ferguson, is on that committee as well, and that is chaired by a dyad, Brian Sandoval from Yakima Valley Farm Workers and Mark Wakai from Providence. And so they really take charge of looking at the aggregated data that the navigators roll up to see what are the barriers, who's where, in what project area, and then how can we overcome some of those barriers, and what are some of the successes that we're achieving from that. So that's really, in a nutshell, that's really mostly what I talk through each step in terms of how we go about doing that work, and I'm not going to take you through every step. But what we have found is that is the step that we're using to implement all of the cohorts, so that we have a standardized process. Everybody's scored the same, everybody enters the program the same, and it has actually been very helpful to have that standardized so that there's lessons learned that we can use to improve the process as we go along.
Carol, can you add about the grace period? I'm sorry to interrupt.
The
period for feedback, let's say for their submittal if there's a deficiency.
Yeah, what is that grace period?
It's 6 days. 6 days from the time that the navigator touches base with the organization in order for them to get the feedback or the corrections of the deficiency in order for them to receive the full achievement of the milestone.
Okay, great. Just as Myers and Stoppers allows us a right back process, we figure we need to extend that courtesy to our providers too, so that they can achieve as much of the incentive money as they can. So, and I know the navigators work really hard with the organization so that they're successful in the program. And then we help them. I'm sorry, and we help them get through that state process, or
yes.
Okay, perfect.
They hold hands, they give hugs.
That's good. I liked it. That's my style.
We need to see next round.
Yes. Trauma informed. Yeah, because it can be very traumatic.
It is.
Traumatic. I'm going to let Wes talk you through the highlights. He came up with this really lovely diagram. It's kind of a workflow of
Lauren, can you go back to
how the process happens.
So this is something that we submitted as part of the quality improvement grant, the very last slide. And this is just a functional systems view. A functional systems view, there's a lot of information on here, but it talks about how we take patient-centered medical home change concepts. So these are the industry standards the big domains that cover practice transformation in the patient-centered medical home. So those are translated into these resources here, which we have been using throughout our program, the Practice Transformation Toolkit, as well as the workbook, and now the CSI reporting portal, the learning collaboratives that Diane and Sam work on together, technical assistance that's provided through the Practice Transformation Navigators, identifying exemplar organizations. This is a really important part of the process where individuals can talk to their peers and learn from them. As well, the Practice Transformation Implementation Work Plan, which are the individual change plans for each organization, and assessments, which is a process that we talked about. So those translate into milestone number 5, which is quality improvement. At the organization level, this leads to the organization creating quality improvement committees and groups and going through the PDSA cycle. From there, that translates back to us through the PT, Practice Transformation Milestone Reporting. If you're part of the Practice Transformation work group, you remember Martine's table that has colored boxes to show how organizations proceeded through the latest round. The PTW reviews it, and then they assess where there's obstacles and areas for improvement. That comes back into improvement strategy translation, which feeds back into the individual organization. So this is a very systematic way of looking at how we do quality improvement, both at the organization level and at the system or region level. Is that confusing? I know that's a lot of information.
That's good. Thank you.
Visuals so good.
It's funny, it's the same kind of pictures that we used 20 years ago. Still works.
Still works. Want
Okay.
to fix it if it's not broken, right?
Carol, other thoughts?
That's our STAR, and like Wes said, we're already starting on looking at STAR 4.
Okay, looks good. Thank you very much. Like I said, I recognize the circle thing. I do check that. Next item you have on here is the summit speaker evaluation results.
So for the summit, for both of our summits that we had this year, for the trauma-informed care and an opioid use disorder, and then the transitional care and chronic disease management, we completed surveys. So each attendee was given the opportunity to provide a survey for each of the speakers that were there. And so that's kind of what this is. And so you can kind of, I'm not going to go too much in detail because we could spend all day on it. But we had really good results. There were only a couple. So just so you know that the trauma and the opioid one, we had 4 tracks. It was very, very robust, to say the least. And so we had a lot, and we had over 240 people attend that summit. So, and they were split up between the 4 different tracks. So we did learn that that's a little much to take on, but we were lucky to have Pacific Northwest University as a partner for this, and also Catholic Charities as well, because it took all of us to put it on and facilitate each location, each speaker. There were 4 different places they were happening at, so it was quite the summit, and that's why we had it for 2 days. So this basically is a summary of each of the speakers, and then how many of the attendees attended that, and then how many, and then it also said what the topics were, and then also the question that we felt, these were the questions we felt that were important. One, will enhance their capacity, competency for their clinic. And so if you go through, you'll see that there are just a few speakers for this trauma one that, kind of were a little bit off the mark. But for the most part, they received, high marks for most of the speakers. And I was really impressed with most of these speakers. I was personally responsible with finding most of these speakers and talking with them all. and they were excited to participate in this event. So we're keeping on the back burner what we want to do for next year as a summit. So that may be a discussion we will have as an organization to try to figure out, maybe we can bring some ideas to the board to see what we're going to do next year. And then I'm going to move on to the next one, which we decided that to do 2 tracks for the transitional care and disease management. And this one, we had, there were almost 100 attendees at this one. And we had 2 tracks, like I said. We had phenomenal speakers for this as well. Sam helped me with this, and so did Carol and Wes with working with the speakers and helping them understand what we needed them to present on. And so you can read the comments. I'm not going to go into them unless anybody has any questions.
Although we should point out that John Gilbert got
Yes.
very, very high scores, and so that is our keynote speaker for the recognition.
Yeah, he was great. He was entertaining. He kept her. He got 100%. I mean, really, he did phenomenal. And so that's kind of why we thought, oh, it would be great if everybody could hear it and not just the people that attended it. So that's why we were bringing it back for the dinner.
So I like to brag on Diane, what she did with this. You can't imagine how challenging it is to find this many speakers for both summits, and to organize them, to schedule them, to make the arrangements, to manage the budget, to manage the venue. Other staff were all participatory in this, but Diane did a huge amount of work. She went to seminars to learn about them. She listened to online videos, looked at presentations.
I learned a lot about opiates.
A lot.
You got up to first.
Yes. No, and that's the whole thing is that the one thing that I love about Greater Columbia ACH is that they provide, and the board has also approved this, but provide that professional development. And in order to be able to find the speakers and things, I went to quite a few conferences on that subject matter so that I could see the subject matter experts and see if they would be good to bring in to have our providers listen to. So I do appreciate having that funding available so that I can attend those meetings.
Yeah, it's really good.
I want to add also, just to boost up Diane some more, I got to sit with her during both of those events and at the registration table, and we had a lot of people come up and ask her, how did you get Vincent Folletti? How did you get Ken Crable? How did you get these people? And she's like, I just called them. I called them. What? We were trying to call them and get them, and they don't return our calls. Their admin says that they're 6 months out or whatever, and she's like, I just called them.
I'm very persistent.
So she got a lot of really high quality speakers that are hard to get.
Yeah.
She did a really good job.
I appreciate you very much for that.
Thanks. Yeah, it was, we couldn't pull it off without our whole team there, facilitating and introducing the speakers. I mean, honestly, it takes a whole bunch of people to put on these summits, and I think that they're really important. And I think this is, in the future, this is where I see our company going in that direction, because it's convening the individuals together to have conversations and learn about the subject. That really, I think that is where I see our future going, because, this transitional care, I mean, at the opiate and trauma one, we actually were able to get a grant, and so
That's right.
We got that $50,000 grant for this, and then we kept the registration cost as low as we could, so that one wasn't free for providers or no cost for providers. But we tried to make it at the lowest cost possible and offer some sponsorships to some individuals if they needed it, but I do think that this is a direction that our company, that the ACH can go into.
No, I think you're right. I think that's
Demonstration
a great thought.
project.
Diane, thank you, because you were the convincer. And you made it happen. Everybody else was behind you and they're supporting you, I'm sure. But you were the one that was on the phone and you were the one that was convincing and that got those things done. And so that alone is yours to own. Okay, thank you.
More to come.
Very good.
But I thought that this would be helpful for you guys to
super.
see
Mhm.
that.
This is great because I like seeing the remarks, but I like seeing the percentages. And I see Becky Rose, who I just adore, has 100%. I'm
Yeah.
going Becky.
She's always amazing.
Yeah, that's really good.
The project was incredible.
So congratulations, Stan. That was very, very good.
Yeah.
Thank you. Next one we got on here is the last item is the cultural competency training in the Yakima Nation at Legends Casino.
Oh, healthy.
Uh-oh.
That was my whole spiel right there.
You just
All right.
did it.
So next week, next Thursday, the 26th, we have the cultural competency training, like Brian just said, at the Legends Casino. It's from 12 to 4. There is a buffet, but make sure you get there early enough to make sure you get through the buffet before the presentation starts. I don't want any grumpy attendees. So, yeah.
So the presentation starts at 12?
Yes.
Okay, then it's really 11:40 or 11:15.
Or 11:30.
Right, 11:20 if you need a second.
Yeah, you
No.
should just lie to us by 30 minutes going forward, just be like 11:30 to 4.
Yeah. I know.
Everyone 11:30 next week?
Yeah, I mean, just go ahead and lie to me. That's fine.
Yeah,
Like we
because
did last
I'll
year.
get there.
It's continuing to build our relationship.
Yes.
And I went last year and I thought it was fantastic and I really was going. I don't know if anybody.
I've got a question. Sure. Can I bring one of my coworkers here?
Yeah.
To this so that she can get that kind of interaction and understanding?
I think there's a registration for it, isn't there?
There's not a registration, but I sent out a reminder, I believe yesterday, letting everyone know that if you plan on attending, please accept the calendar invite. And if you don't plan on attending, either decline or send Chelsea or I an email just so we can know for catering purposes.
Okay. That's all good stuff.
It's on my calendar for a while.
Yeah.
What other stuff do you have? Okay, is there anything else that, yes, sir?
Point of personal privilege, I don't know, it seems like a month ago, but I think it was just a week or so ago. One of my peers and I got to travel to the west side to rub shoulders with a couple of other organizations over there as they developed their community paramedic programs. While I didn't expect it, I got to hear feedback about these types of organizations. And just like in all industry, not every ACH or every organization is created equally. And I walked away being extremely grateful for the work that you guys are doing. You're phenomenal. When you're on the west side and people make a comment that you have a great ACH, what that tells you. So I heard other things too, but I won't repeat those. Those aren't about this ACH, so we'll let those lie. But you guys really are doing a phenomenal job. We are all blessed to be a part of this and work with you, and keep up the good work.
So Eric, do you want to, since we have like a little bit of time, do you want to tell us where we're at with the community paramedic program there?
And since we have Myers Crawford, can you give just a little bit of background before and then tell progress?
Yeah.
They're not putting you on
Progress report isn't supposed to happen until January. Right, we are absolutely in implementation mode. In fact, the reason why Kerry wasn't at leadership today is because he's in Spokane, jumping on with their ACH's training for motivational interviewing.
Right.
So I was just about to call in a favor when they had a spot open up. But so the Kennewick Fire Department on July 1st of this year, we say hired, but he's worked for the department for almost 20 years, moved one of our captain paramedics into a community paramedic program. And so our focus of our community paramedic program is really to identify individuals that are obviously typically in a single family resident type living situation in which they are either disconnected from services altogether, or the services that they're connected with, something is not lining up, okay? So we tend to see that obviously in a very raw form, and so we are beginning a program that will really just go in, meet with the individual, build a rapport. That's huge. We're figuring that out very quickly. And then not necessarily doing anything special other than connect them with resources. And so we're very excited about it. The GCACH has helped us out a little bit with the expansion of our EMR, which we needed in order to be able to, this is new work for us. This is not typically what we do. It's not burning buildings or people dying right in front of us. And so we're having to adjust how we work there, and we needed an expansion of the EMR in order to be able to do that more appropriately. So we're getting that all squared away. And then Carrie, that's our community paramedic, we went to the west side. We spent time with East Pierce Fire and Rescue, and then South County, who we previously known as Snohomish County Fire District number 1. What is really cool was the East Pierce model is almost exactly what we already had planned, and so they just helped us kind of tie in a couple of things, and we're really excited. So we'll give our first official report in January, and we were already making some big strides with some individuals that are responsible for a lot of call volume. We have, just as a data point, in 2018, we had 371 people who accounted for over 1,700 calls. So those are the people that we're targeting to reduce that impact on 911 and then ultimately the emergency rooms. So, yes, ma'am.
How does the ACH help you?
What the ACH did was helped us with one of the recent SBARs, I think in June it was, to expand the documentation module.
Okay.
Thank you.
With funding.
With funding.
Yeah. Isn't it all about funding around here? I mean, the smiles are nice, the food's great, but...
That was awesome.
No,
we should write that down.
That should be our motto, yeah.
I think so. Maybe
Smiles are nice.
But it's all about fun.
But it's all about fun.
Nice.
I guess the bigger question is are you going to be able to show the dollar savings? Because those are a huge burden on the system.
Right.
And, and it's really hard to quantify releasing a burden,
right,
and really tell people that it's worth it in the long run.
So on October 1, we started a study that I've been working with Wes and Sam to frame. And that study is to not only look retrospectively at a period of time of people that utilize the 911 and emergency room system at a certain quantity, and then as we progress, look and see where some of those same individuals or individuals with very similar dynamics, whether it continues or doesn't, and we'll include a control as well as a study.
That's what I was wondering, are you going to randomize this out? So
yeah, we are.
I hate that idea because you don't get to help some people, but it makes a difference.
Yeah,
That's the original intent, to have a study in a control group.
Yep.
It's called design of experiments. We look for statistical differences between the two groups.
And if successful, we'd like to scale that as image trend is for our whole greater Columbia region, with the exception of 2 that are not utilizing it but have the resources to have it.
well, within the Tri-Cities.
Yeah, right.
Yeah, and
Well, we're finding it across.
we are, and there's some other expansion towards Walla Walla, or so it appears. So,
Okay. Really
Thank you,
good,
Eric.
thank you.
So that wasn't what I intended to say, but.
All right, that
Thank
works,
you.
that works. All right. Other thoughts, y'all? Maybe we can get a couple minutes, right? You have a motion to adjourn?
Yep.
Not early? Yeah. Okay, very good.
All in favor?
All in favor.
That's how you move to adjourn.
All right, guys, thank you all very much. Appreciate you getting down.
Thanks, Brian. Appreciate you being here. Brian for filling in.
Yeah, good job, Brian.
At the last minute.
No problem, I had a feeling.
You got a feeling.
That's right.